Good afternoon, everyone. Thank you for joining us on this week's COVID-19 clinical webinar for all of our Sound clinicians. This is Mark Rudolph, Sound's Chief Experience Officer. As always, we will have some time for live Q&A at the end of the presentation. Please type your questions in the chat box that is at the bottom of the webinar control panel. And we are recording this webinar and we'll send it out later today via email to all of the invitees with a link to both the recording and any resources that are mentioned. Today, we're fortunate again to have Rob Bessler, Sound's CEO and founder, with us, and so I'm going to turn it over to Rob for a couple of comments. Rob?
Thanks, Mark. I'm glad to be with everybody today. And I know you're most anxious to get to the actual clinical content, which I'm so appreciative of. I wanted to share a personal story, and we've all been patients in the healthcare system, and I think every time I've ever experienced the healthcare system, I come from a place of, wow, what could be better, what I could do differently, what I will do differently in my practice. And I'll just share a personal experience about for Saturday, a week ago Saturday, I started with a mild cough. My wife's a pediatrician. Obviously, I've been in and out of hospitals for a long time. And I immediately moved over into my detached garage mother-in-law suite. And by Monday, it was pretty bad, and a week ago Monday, and got a test. Luckily, it came back negative. But then I quickly realized and was very appreciative of these webinars and learning about the sensitivities of the test. And then super appreciative of some of the learnings we've had, because like every possible therapy, I've had access to from people on these calls, and of course looked at all of them. And I also had a pretty anxious last Thursday, Friday night with extraordinary tightness in my chest and desatting with movements, but 93 on a pulse ox that my wife went out and bought. Luckily, I'm on the mend now, and I just wanted to say thanks to everybody and have this it just kind of framed the opportunity before us, the challenge before us, and left me with just a great sense of appreciation for what our organization is focused on and how we're focused on how do we do the best for our own people. And if we do the best for our own people, we're then in a position to do the best for our patients and the communities we serve. And it's been very grounding for me of how important the work that we do. I just want to reflect on that and pass it back to you, Mark. Thank you.
Thanks, Rob. Glad to know that you're on the mend. I'm going to introduce.
It is nice to take a deep breath.
I'm sure. Most of you are probably familiar with our three clinical service lane CMOs. Nate Ruck is our CMO of Sound Emergency Medicine. Greg Johnson is CMO of Sound Hospital Medicine, and Sergio Zanotti is our Chief Medical Officer of Sound Critical Care. And I'm going to turn it over to them for the presentation and discussion.
So thanks, Mark. I think everybody's pretty familiar with the agenda that we've come up with. We'll provide a brief update with respect to just Sound-specific experience with COVID and the number of cases. And then we're going to go over some guidance specifically around what you see there, admission criteria, treatment guidance, as well as discharge criteria before we get to our question and answer. So going into the Sound update, we've historically shared a lot of information with respect to numbers. I think, when you look at Sound's heat map, it looks a lot like the heat map that is associated with many of the other sources that you may get access to. For us, I think the big thing that we're highlighting is that, there's been incremental increases in terms of the number of positive cases that we have going through the Sound Connect input that we're so grateful for all of you in critical care and hospital medicine and applying. We are noticing about another 600 patients per day increase, with about a quarter of those actually turning positive, confirmed, with the remainder being positive but away, or being negative, or really about pending testing. And so we're careful to monitor these. Obviously, we are knee-deep in terms of our experience and what's going on in New York City and New York State. And as Rob expressed his gratitude, I'm tremendously grateful for the teams that are working there, but quite honestly, everywhere in terms of their response. And we'll continue to be able to track this information and report it out to you on a regular basis.
Thanks, Greg. So this is Nate Rook, the CMO for emergency medicine. And Sergio, Greg, and I, along with others from Sound and Support, have been working together to provide the ability to backfill very urgent PPE needs. And as many of us are aware, there's been substantial shortages in some parts of the country. And here you see a screenshot of the Knowledge Center with the link to request PPE, and this can be filled out by your chief or your regional medical director. And just to give you a flavor for what's happened so far, we've distributed as of today 3,450 KN95 masks. We've had requests from 67 sites, and those sites represent critical care, hospital medicine, emergency medicine in all Sounds regions. And later this week, the program will expand to be able to provide surgical masks, and those, we'll only have a limited quantity. So we're really not looking to provide, kind of baseline supply, but are looking to help facilities that have truly critical shortages and no local supply. The and the N95, equivalent masks, we're really reserving those for places where there's aerosol exposure, i.e. intubation or work in the ICU. So another thing that we want to distribute to everyone and just say a few words about, we've done a lot of discussion on testing in this forum, and the FDA and CDC have collaborated to come out with a fact sheet for patients on testing and how you interpret it. And there'll be a link in the slide deck, as well as a copy of the PDF and the material that gets distributed after this. And it goes through some of the things Rob alluded to in his opening comments and some things that we'll discuss more as we move forward in this presentation. Primarily the point for everyone to understand is that a single negative test does not rule out disease, particularly if you're in an area with a fair amount of prevalence and your pre-test probability of disease is high. So moving on from that discussion of testing and that new resource, we'll talk a little bit about evaluation and the decision to admit patients. I'm going to take this from the emergency medicine perspective, but I think it'll be useful to all the clinicians on the call. And just some guiding principles. If you're in an area where testing is constrained, which is really many of our sites, you don't need to test people that have mild disease that are ambulatory, because the reality is that the single test that you perform won't really answer the question they want answered, which is, do I have it or not? I do think that there'll be widespread availability for antibody testing, but that's, likely several months away. The majority of patients don't require hospitalization. For people that are discharged, really the focus should be on preventing transmission and also on communicating what are indications to come to the hospital. There's guidance on home isolation that is, doesn't necessarily have a tremendous amount of research behind it. And, some people are saying, well, you should wait a week from symptom onset, you should be fever-free. Others are talking about testing-based methodologies for eliminating isolation. I don't think those make so much sense for ambulatory patients. The other thing to keep in mind when you have patients in the ED or elsewhere in the hospital is that you don't need to meet PPE de-escalation criteria to be discharged. You can self-isolate at home. And I think now more than ever, it's important that we're alert for alternative diagnosis. I know when I look at my calendar and I think about what my clinical shifts recently have been like, it's kind of all COVID all the time, but people still present with other problems. So we should all be vigilant. On this slide and the subsequent slide are a framework for evaluating people with symptoms suggestive of COVID-19 that's been put together by the University of Washington. They've updated it a couple of times, and basically, they, like many who are screening a fair number of patients, utilize initial oxygen saturation. What is your pulse oximetry at rest when you arrive is kind of the big decision point. And if you have resting hypoxia and comorbid disease, then you're likely to meet criteria for admission. If you don't have resting hypoxia and you don't have, high risk criteria, then you can be managed as an outpatient. And from a kind of a history and epidemiologic standpoint, those big risk factors are age, hypertension, pre-existing pulmonary disease, diabetes, particularly with a hemoglobin A1C above 7.6, chronic kidney disease, active malignancy, particularly those getting chemo, some biologics, although the evidence on that is really extrapolated from other illnesses, and certainly transplant or other immunosuppression. And you can see even in this algorithm for low-risk patients, utilization of a COVID-19 test is per the clinician's judgment. It's not mandated. For patients that you're admitting, I do think testing is useful because if it's positive, it reinforces your use of appropriate cohorting. So this is the second part of the algorithm, which goes into some detail about the risk factors that I outlined, and also talks about, well, what do we see on a lab perspective and from a lab perspective? And again, patients with mild disease that don't meet criteria to stay in the hospital probably don't need any of these labs, but those that have them performed, we have a pretty good idea about what the lab, kind of phenotype of disease looks like. And there's some things that are prognostic of a more difficult course. And a D-dimer, greater than 1,000 nanograms a milliliter, CPK twice normal, LDH above 245, elevated troponin, marked transaminase elevation, a new creatinine elevation, and and lymphopenia is common in a lot of these patients. But if you have an absolute lymphocyte count less than 0.8, that's an independent predictor of more severe disease, as is an elevated ferritin. So, as you think about admitting these folks, the other point on here, which I think is worth mentioning, is what is the role, and Sergio has spoken about this on previous editions of this webinar, what's the role for chest CT? And I think that we need to be mindful of utilization of chest CT unless it's going to change what you do clinically. If you have a high index of suspicion of an alternate diagnosis, PE or dissection, maybe a chest CT is useful in that patient. But if you already know that the patient's hypoxic, they have an abnormal chest X-ray and they're being admitted, it really makes sense to spare exposure to your CT technologist, spare your facility having to clean the CT scanner, and minimize the transport of a potentially infectious patient through the hospital. So I would encourage you to use that sparingly and really only in situations where it's going to alter your management. Discharge from the emergency department. Sergio will expand on this later, but no agent has proven efficacy for treatment in COVID-19. There's preliminary data, which I think for essentially all the agents is really at the kind of hypothesis generation stage, and that includes hydroxychloroquine. Many facilities have protocols that have been developed in collaboration with ID, and I would encourage you to follow those. But I would also remind you not to feel guilty if you're not providing anything beyond supportive care, because that's really what the evidence supports today. There are a lot of investigative therapies, and I think in time we'll know a lot more about what works and what doesn't. But today that's an evolving space. Like we talked about earlier, discharge instructions really should emphasize infection control and when do you need to return. If your shortness of breath is worsening, if your comorbid disease is worsening, and giving people good practices that they can utilize at home so they don't infect others that they live with. So now I'm going to hand off to Sergio Zanotti, the CMO for critical care, and he's going to take us through clinical treatment guidance.
Thanks, Nate. And again, want to reiterate our message of appreciation and a big thank you to all our providers at the front lines. I know that no matter where you are dealing with the effects of COVID-19. Some of our teams really have been hit very hard, and some of the stories that we are hearing from the front lines are truly remarkable. And I think not only brings a tremendous amount of gratitude to myself and the team, but also a tremendous amount of pride in what our sound clinicians are doing to try to help the communities they serve and really make a difference. So I think that one of the biggest problems with this whole epidemic has been the infodemic of information, of looking for what new can we do, what can we do differently. And I think that we need to root ourselves in medicine and the way we have treated patients for a long time, and understand that we always recommend that for a viral disease, we treat the symptoms and we support the patient. For most viral disease, that has been our MO, because we don't really have, tremendous proven therapies. And I think that in COVID-19, it's no different. So what we wanted to do today is really focus on what we think should be the top areas that our clinicians should be focusing on, and that if we can really succeed with these, I think that we could have the greatest impact for the greatest number of people. And those include, number 1, infection control and prevention; number 2, respiratory support; number 3, supportive interventions. I will address specific therapies like Nate said. And finally, I think something that is extremely important, and we're seeing this in the front lines, is goals of care and family communication. So those are the 5 areas that I will share with you what I think we should be all doing in terms of providing the best care possible under, in some cases, very difficult circumstances. So in terms of infection control and prevention, and I think that when we had our webinar a couple of weeks ago on rational use of PPE, I was very clear in saying that there's what we need, there's what we want, there's what we need, and there's what we have. I think that what we want is obviously to be safe. What we need to be safe, I think, is an evolving target, but we do have a lot of information that there's some practices that can keep us safe. And I think that among those, there's the 3 situations that I wanted to share with you. And everything that we recommend, I think, has to be taken within the context of what is going on the ground in your facility. Because I think that the fact that the supply chains are impacted the way they are, and the fact that the number of patients in some places is so overwhelming, is something that obviously nobody had planned for appropriately. And that is something that is causing trouble at the bedside. And it's one of the reasons why the CDC has had evolving recommendations in trying to provide the best available recommendations for people to consider. So I think that for all patient encounters, especially as the prevalence of COVID increases in your community, it does make sense when possible to put a surgical mask on patients with respiratory disease or any suspicion, and for us ourselves to use a surgical mask and gloves, obviously with pre and post appropriate hand washing. Now, that might be possible in many of our hospitals. It might not be possible in others, but I think that it's a first step with patients who you're not thinking may be COVID, or you don't know initially, of decreasing the risk of transmission. For those patients who are being investigated, so patients under investigation or COVID positive patients, ideally, if you could have them in an aerosol negative room and you could use N95s, that would be the perfect situation. But the reality is that most of our hospitals that are seeing these patients have far run out of negative pressure rooms. And what the current recommendation is that for short interactions that are not related to potential of aerosol dissemination, patients should be masked with a surgical mask, and that the providers should have a face shield, should have a surgical mask, should have a gown and gloves, and be very diligent in washing their hands before, and especially when they are removing the PPE in between each step in a very deliberate manner. For those situations that include high aerosols, which are intubation, extubation, nebulization, perhaps BiPAP, bronchoscopy, tracheostomy, the recommendation would be for best protection is that in those cases, in addition to all the face shield, the gloves, the gown, and the proper hand washing, that we also use N95 or equivalent respirators during the procedure, and if possible, that procedure be done in a negative airborne room. So I think that from infection control and prevention, we believe that these are 3 situations that we're going to encounter over and over again, and trying to be very diligent about the things that we can control, working with our hospitals, and optimizing the use of PPE, I think is going to be very important. Now, the hope is that as this continues, the supply chains get better. Nate alluded to the efforts that Sound Physicians has embarked in to try to help those teams at the direst situations. But I do think that there's still always things that we can do to control what we control that we can do to try to minimize our risk. So number one, infection control and prevention, and think about these three situations. Number two, I think is the mainstay of treatment. And I wish we had, I mean, obviously a lot more information. I think people want recipes of what to do, what not to do. And I think that we still have to be clinicians, although I think that as the numbers become overwhelming in some places, that becomes very difficult. But I think that the mainstay of treatment for these patients who are admitted, and the ones who are going to be admitted usually will have obviously a pneumonia or what we call a severe acute respiratory illness associated with COVID-19, and they'll be hypoxic. So the goal is to keep their oxygen saturations above or equal to 90, a range of 90 to 96% for most adults. In patients who are pregnant, we might want to push that a little bit higher, 94, 96%. And I think that one of the numbers that keeps coming over and over again is that when patients get to a 6 liter per minute of nasal cannula, if they are still having difficulty with hypoxemia, that might be an indicator that patient might need to be escalated, and we'll talk about what that means and how that has evolved. Another topic that has become very popular in discussion regards to, are there any benefits in placing these patients in the prone position, which means on their belly, and see how they tolerate? I think that there might be some theoretical benefits. Some people anecdotally within Sound have noticed that patients feel better, have documented better pulse oximetry and better gases. I think that what's appropriate is to ask the patient in what position do they feel better and to try that. But it might be something that we could be doing that has no harm. It might have benefit in our patients who are on the floors, is just recommending that if possible, when they're sleeping or when they're resting, they do it on their belly in the prone position. And I can talk a little bit more about that when I talk about mechanical ventilation. In terms of escalation, there's been a lot of controversy and discussion about the potential dangers or potential issues with using non-invasive ventilation or high flow nasal cannula. So let me address first the issues related to potential dissemination of aerosols. So the thought is that with BiPAP, especially with a not very good seal or only with a nasal prong, there could be an increase in aerosol production, which could, in theory, increase the risk of healthcare providers contracting the disease. That is one issue. That is probably less so with high flow nasal cannula. Now, there are other issues that I think are also important to consider that relate to what works better in patients who have pneumonias or have ARDS type pictures. And I think that the track record for non-COVID would be that probably high flow nasal cannula would be a better option than that, than BiPAP. And there's also additional concerns that patients who are having a very hard time breathing and are not getting the support they need might be causing ongoing lung injury in the same way that somebody on a ventilator with very high tidal volumes could be suffering. So I think that in general, what has been recommended is that high flow nasal cannula be an option before BiPAP, or probably more likely to be useful. And in any of these cases, be very cautious with the potential for aerosols. In any of these cases, I think what's highly recommended is that you evaluate the patient and monitor them very closely, and that in any case where you think that they're using accessory muscles or they might not be tolerating very well, that you really go very, very shortly to intubation. And that's the whole idea of early intubation, not prolonging patients on these modalities without good success that could cause more harm than benefit. And that is supported by the Chinese critical care series published in Lancet that suggested that patients that were on BiPAP before going on mechanical ventilation seemed to have a worse outcome than those that got intubated early, and similar observations elsewhere. Now, the caveat to that is that that also depends on what's going on in your hospital. In some places, such as in Italy and New York, obviously, I mean, if you start intubating everybody, you might be intubating patients that could have gone without intubation. And in those cases, eventually, the lack of ventilators could be something that could be problematic. So I think that initially, the recommendation is to try to go as early as possible to use high flow over BiPAP, but the situation on the ground might dictate that at one point you're using whatever you have available, and I think that acknowledging that reality is very important. The other thing I want to mention about escalation therapies is that when you have patients that are going up on oxygen and they're passing 6 liters per minute, if they're on the floors, you should be talking with your ICU teams. You should be making sure that you have a definite plan. Is this a patient that's going to be intubated if they get worse? Or is this a patient that is a DNR and should not be intubated, in which case, I mean, your strategy would be very different. But having those conversations with your respiratory therapy team and with your critical care team, I think is going to be important in terms of planning the best way possible, especially as the numbers in some hospitals might start going up very quickly. And finally, the last level of respiratory support that we're going to talk about is mechanical ventilation, which has obviously received a lot of attention because of the fear that we would run out of ventilators. I think that the concept of early intubation is still something that applies. I think the idea being that there's been high failure rates and that some of these patients are probably protected by early intubation, heavy sedation, and the initiation of what's known as lung protective ventilation. Something that has emerged that I think is very important is the fact that these patients with COVID-19 pneumonias early on have severe hypoxemia that is related mostly to VQ mismatching. And we'll talk a little bit more about that, and that might be related to vasoplegia and microthrombosis. We're still trying to understand further. But what's different about these patients and traditional ARDS patients early on is that these patients have preserved lung mechanics, so their lung compliance is actually very, very good. And in that respect, maybe what's more important initially is to support their oxygenation, to use a tidal volume that's protective, but it might not need to go to 4. You might be able to do it with 8 mLs per kilogram. And if your plateau pressures are below 30, which they usually are early on, and if your compliance is good, that might be a good place to start. In terms of PEEP, PEEP has actually been recommended to be utilized. I think what people are seeing is that early on, you probably can get away with less PEEP because the lung is very compliant and it's not as recruitable as you would say in critical care. But as the pneumonia progresses, sometimes these patients behave more like a ARDS patient, and in those patients there might be more recruitability and higher PEEPs might be needed. But I think that the message really is that we should try to use the least amount of PEEP that we need to in order to try to achieve our goals of oxygenation and taking in consideration plateau pressures and what we're doing in terms of protecting the lung. For those patients who, despite these interventions, are still very hypoxemic, and that is defined as a arterial pressure of oxygen divided by your FiO2 below 150, people have proposed prone position. Prone position seems to improve oxygenation. It protects the lung and ARDS in many ways, but also might improve distribution of blood flow to better aerated areas, which might be a mechanism, and people have severe VQ mismatch. What we've noticed in the patients that we've prone so far in throughout the country, but also throughout Sound, is that even if they respond, they usually need more days than are seen in ARDS patients. And I think that that's something to remember, and also something to remember that these patients are taking longer to recover than some of our traditional pneumonia patients. And if you think about the natural history of the disease, it takes at least 8 to 9 days for you to get sick. So I think that if it took 9 days for you to get to that position where you're critical, it's not going to go away in 2 days. So you should almost think like a mirror in terms of, and that is something that we see very commonly in clinical medicine in general. If you have something that gets very acutely out of control and it's fixed, you can very acutely and very quickly get better. But if it takes 8 to 10 days to get to that peak of critical illness, it might take a little bit longer for you to recover. And that has important implications when we're trying to wean these patients. They're probably going to be on the ventilator a little longer than most of our other patients. So I have to be patient. Finally, other salvage therapies, I think that for places that have ECMO, having the right ECMO criteria within Sound, we probably now have almost double-digit ECMO patients in in all our programs. I think that if you're a place that does ECMO, that's great. You should have your criteria and apply it in the same way. If you're not a place that does ECMO, you can try to maybe refer them based on certain criteria. but this is not the time to start doing ECMO just because of the improvement benefit, but also the amount of resources that is required. So this is actually, I think, a very nice algorithm that also illustrates how there's a lot that we still don't know. This is from the Society of Critical Care Medicine, the European Society of Intensive Care Medicine, through the Surviving Sepsis campaign, which I think is a very well written document by 20 experts from around the world, some of them with a lot of firsthand experience. I like the document because I think it gives you their methodology for grading the evidence. It gives you all the evidence, the rationale, and it gives you all the references, which you can then go and look yourself. But ultimately, what they're telling you is that there's a lot of unknowns. And as you can see, we have 3 markings here, which are consider, which basically says maybe, but we don't know. Do it, which is very few things and things that I think we all agree with. And then do not, which might be things that could be actually harmful. So in those patients who are hypoxic, if they require endotracheal intubation by regular criteria, you should go ahead and intubate them. You should have the most expert person doing the procedure, and you should use N95 or equivalent with all the other PPE precautions while you do it, and minimize the number of staff in the room. What's recommended, and we recommend it to all our sound teams, is to use a video laryngoscopy instead of direct laryngoscopy. And the idea is twofold. It improves your first pass success, but also it distances the operator from the airway and from the potential aerosols. Now, if you don't need intubation and you're tolerating oxygen, again, like we said, monitor the patient closely, target the SiO2 from 90 to 96%, and do the appropriate infection control precautions like we talked about. Do not delay intubation if the patient's worsening. For some patients, if they need a little bit more oxygen, perhaps a high flow oxygen trial would be reasonable, and especially in patients who you think you might be able to get through without intubating. Young people who might require a little more oxygen, who are stable in other respects, because these patients are very hypoxic, but they don't look as sick as some other patients with other respiratory diseases because of the VQ mismatch, might be candidates. But again, if the patient is not tolerating it or getting worse, I think that the overall indication is to go to intubation early. And then the last thing, like I said, non-invasive positive pressure ventilation through BiPAP is something that we really put as the lowest level of escalation due to all the concerns that I mentioned. Having said that, I think in a lot of situations, patients are being placed on BiPAP just because of the reality on the ground. And in those cases, you should monitor very, very, very aggressively. And if they're not getting better, really move to intubation as quickly as possible. So that kind of summarizes, I think, the approach that we should be having to the respiratory support in these patients, which ultimately is probably one of the cornerstones of getting these patients better. Supportive interventions. Nate mentioned that the treatment for COVID-19, in terms of what we know works, is supportive. I think that we could talk about a lot of things, but I just wanted to touch on 3 big buckets: general medications, fluid management, and prophylaxis. So for general medications, I think that most people would agree that appropriate empiric antibiotics, since we're treating a possible pneumonia and we're not sure exactly what's going on when we admit them, is very reasonable, with a plan to de-escalate if nothing grows and the COVID comes positive and then you don't think it's bacterial. There's been a lot of talk about NSAIDs as potentially being dangerous. The reality is nobody knows, but I do believe that most people feel that for symptom control of fever, acetaminophen is probably a safer option right now, and I think is what's recommended. In terms of other medications, there's no role for MDIs other than symptomatic relief of bronchospasm or people who have asthma. But if you're going to use these drugs, I think meter-dose inhalers are better than nebulizers for the concerns of aerosols. And that obviously has put a strain on the supplies of MDIs, but I think it's something that you should be thinking of in your hospital and talking with your pharmacist. And finally, I think that there's been a lot of talk about corticosteroids. The bottom line is that these patients should not be receiving corticosteroids routinely. I think that there's still indications for corticosteroids for other reasons. So for example, if they had an asthma exacerbation or they have other reasons in which I would use the shortest and the lowest amount of steroids possible. I still think that there's debate whether corticosteroids could be helpful for very severe ARDS. That's a debate that's been going on for decades, and I don't think that it's resolved outside of COVID or within COVID, but I think it's hard to make a widespread recommendation. What we do know is that in other viral pneumonias, such as SARS and MERS, corticosteroids has been associated with prolonged viral replication and not with significant improvement, which is why it shouldn't be given to everybody. Fluid management, I think, is another very important topic. The reality is that when these patients first come, you need to get a little bit of history. If somebody's shows signs of AKI, if somebody's been having fevers for days, they likely are intravascular volume depleted, and on admission and acutely, they might benefit from some fluids. I think that the recommendation is to give small boluses to really just, not overflood these patients, but you do it judiciously. Maybe not everybody gets 30 mLs per kg, but you have to be a clinician there, and I think that's very important. As the disease progresses, what we've seen in a lot of our places that have been hit very hard is that acute kidney injury is a big problem. So you actually have to be careful in terms of not exacerbating that by being too aggressive with diuresis up front, which might cause more harm than benefit. But I think that once the patients are admitted, they're more stable, the fevers are controlled, I think that we have to be very conservative with fluids and try to keep them balanced towards a negative fluid balance as they get sicker, which is something that we have shown in ARDS to be very effective. So I do think that these are things that obviously you have to be managing, but I do believe that it's not one size fits all, but you also need to understand where the patient is clinically in their physiopathology. But overall, I would say that our approach to fluid is to be conservative, and eventually, as your disease progresses, to really try to keep them on a negative fluid balance if possible. Finally, prophylaxis I think is very important. There is clear indication that these patients are having vasoplegia, microthrombi, and macrothrombosis. Anecdotal, but also reports of autopsies from Italy. I think there's something that is causing, probably a lot of problems. We still don't know what the right answer is, but I think that checking the D-dimer, like Nate said, is a great thing to do. These patients should absolutely be on DVT prophylaxis. Where these patients should be anticoagulated, I think is not defined yet, but I would say that you should have a very low threshold to anticoagulate for any suspicion or evidence of macrothrombosis. I've seen people on respiratory, on renal replacement therapy develop enormous clots in their systems that are really remarkable. So clearly people on RRT, people on ECMO are being anticoagulated, but I really urge you to be very aggressive with your DVT prophylaxis, aim towards higher doses in that respect of what you usually use, and be very vigilant both for the D-dimers and also admission, but also for any potential indication of macrothrombosis that would require anticoagulation. Other things that I think are just important to remember for those who are intubated, GI, enteral nutrition as soon as possible, GI prophylaxis for those who have coagulopathy or mechanical ventilation for more than 24 hours, which would be all these patients who are intubated, and also obviously taking all the precautions we can to decrease the incidence of catheter-associated infections. Specific therapies, I think echo what Nate said and echo what the FDA and the CDC and many scientific societies have said. There are no proven therapies for COVID-19. No proven specific therapies. Everything that is out there is experimental. I think that there is obviously a tremendous desire from the community and from patients to have a magic bullet or a game changer. But if you Google game changer plus COVID, you will find a long list of things that have really not changed the game at all. The only game changer so far is the virus. And I think that at one point, as an organization that has over 4,000 clinical providers, we have to give advice that is based on science and that is based on a principle of providing the greatest good for the greatest amount of people, which I think in a situation like this, when there's so much anxiety, starts by not causing harm. So chloroquine and hydroxychloroquine have been touted by the press, have been touted by authorities as a game changer and miracle drug. The reality is that the data is very, very scant. There is in vitro data, which by the way has also been shown with these drugs for many other viruses. So it's nothing unique to COVID. And there is very little data that's published of very marginal, I think, quality, just because of the numbers and the methodology. So we have to be very, very careful. Now, I do recognize that in a lot of our hospitals, and a lot of protocols are saying in conjunction with ID, you can discuss it. But I do believe that the stand should be that the best way for people to get these drugs is through clinical trials. We should try to be part of clinical trials. And if we're not, I think it's an individual decision. But I do believe that people need to understand that the data is very, very preliminary, and that this is mostly driven by fear and by the desire for magical thinking. Number two, remdesivir is a drug that also has been touted as potentially useful. It's an antiviral that was developed for Ebola. There was access to this drug for very sick patients on a compassionate basis. Sound patients have received that, but now I think it's mostly through clinical trials, either by NIH clinical trials or by clinical trials that are done by the company that produces the drug, Gilead. Lopivirine and ritovirine, which is Kaletra, was also touted as a potential drug. We do have a randomized trial that was published in the New England Journal of Medicine last month with over 200 patients and showed no benefit. So I think that this is really something that right now there's more evidence that it doesn't work than anything else, and I really don't think that it should be utilized. IL-6 inhibitors such as tocilizumab have been proposed as well for the cytokine storm. Again, I think that some people are getting this. There are trials ongoing. Again, the evidence, even what we're hearing anecdotal, I mean, is not there to say that everybody should get it. But if you can get access to these trials, that would be phenomenal. And finally, the use of convalescent plasma. This is based on a report of 5 patients out of China. These 5 patients got better 12 days after receiving the plasma. They got 1,000 other interventions, and there's really no link scientifically to say that they got better because of the plasma. And in a country where we had thousands of cases, the evidence that people are using is based on 5 patients. Now, I'm not saying that this doesn't work, but I do think that convalescent plasma should be done through an experimental application that the FDA is giving. And I think it's something that people are very excited about, and people are asking, where can I donate plasma? Where can I get plasma for my family member? But again, I mean, 100% experimental, and I think that there's still no evidence that people should be getting this outside of the context of a clinical trial. Now, I understand that this is disappointing for people, but I do think that as CMOs, we have a responsibility to provide the best information possible. And I also understand that some patients are getting this off-label, but I do want our clinicians to be very clear on where the data stands and where FDA, where the CDC, where other organisms stand from a scientific standpoint, because I can assure you that if it weren't for a frenzy and a pandemic, none of these drugs would be utilized at the bedside in the way they're being utilized right now. And that, I think, is something that we have to be very careful with. Finally, the last thing that I want to talk about, which is perhaps the most important thing in a situation like this, can we advance the slide, is the human part of all this and the toll it's taking on families, on patients, and on providers. This is truly unprecedented in terms of the numbers of patients that we're seeing. It's unprecedented in terms of families not being able to be at the bedside, not being able to be at the hospital, and people dying by themselves. So I do believe that probably the greatest good we can do as providers for ourselves and for the people we're treating is to have a deliberate focus on good goals of care and the best possible family communication under very difficult circumstances. So I would say that early goals of care discussions, your advanced care planning, that should be done when we get the families, when the patients come in as soon as possible. I mean, even for patients who maybe are being discharged for other diagnoses, who might be at high risk, we should be very aggressive in making sure that we understand what people really need and want for their care. Because I do believe that when EDs are overwhelmed, ICUs are overwhelmed, it can be very easy to proceed to aggressive care or trying to provide aggressive care, but maybe for some of these patients that is misaligned with what's best for them and what they wanted. So very early goals of care discussion, and you might have to do that over the phone, but I think it's something that we should all be doing in the ED, in the ICU, and on the floors. I think that we should figure out, as our COVID numbers increases, some type of process for family communication. Now, with a lot of patients and with everything that we have on top of this, it might be difficult for the clinicians to communicate with every family in the way they want to. However, I can assure you from my own experience, working a shift a couple days ago, that at the end of the day, perhaps the most valuable thing I did was the time I dedicated to the son of a patient who was intubated that day with COVID-19. And I realized that perhaps was the greatest impact I'd had that day. And I do believe that for our own well-being and our own purpose-driven kind of focus through this crisis, finding the opportunity to connect with families and connect with patients is going to be very important for everybody. And finally, I think this whole idea of providing a good death, and you can see a picture of a COVID patient who's dying or is going to make DNR, is not going to be intubated, saying goodbye to a family member via FaceTime. I think this is something that our teams have experienced. I want to give a big shout out to our team in NIAC. They at one point tried this initiative called Nobody Dies by Themselves. And I know that one of our APPs stayed with a patient, an elderly patient who was dying by their side. And what that meant for the family the next day when they understood what had happened was tremendous. And obviously, we can't maybe save all these patients, but I think that recognizing the value of being compassionate in these moments more than ever, I think is something that is often overlooked in the frenzy of what's the latest drug that we should be using, and is something that, for as long as I know, has worked in medicine. So I will stop there, and I think Greg is going to go next.
So I'll, as we're getting into discharge criteria, I'll acknowledge that we'll try and leave some time at the end to get to some of the questions that you may have. But as Sergio went through the clinical treatment guidance, a lot of what we are doing is saying once our patients have received this appropriate supportive care, what happens next with them? And so if you advance the slide, I think the first thing that we want to make sure to underscore are that, is what Nate and Sergio had stated before, which is you have to be a clinician and evaluate what's going on with the patient in the given time. So if the patient looks like he or she is ready to be discharged, then the CDC guidance that is attached to this particular slide under the highlight of discharge is really underscoring that you've got to make the determination that the patient is ready to go based on your clinical understanding of the situation for that individual patient and for what is available in the community. And reiterating what Nate stated in terms of evaluating what happens in the emergency department goes the same for discharge from the hospital, which is that discontinuation of the transmission-based precautions isn't a prerequisite. So again, patients can go home, patients can go to skilled nursing facilities, patients can go to long-term care facilities with particular precautions that I will get into shortly. There are two questions that have commonly come up since we've started these webinars about discharging patients. And very specifically, it's when do you discontinue the precautions that are associated? And this is really split up between whether or not you're taking symptom-based methodology versus test-based. I think Nate very articulately highlighted that a test-based methodology may not necessarily be all that beneficial just because of the sensitivity associated with the testing. And a lot of what we're doing, particularly for patients that are being discharged home, is going to be focused on symptom-based. And what's outlined here is what's outlined on the CDC website with references. Specifically, patients got 72 hours since they've defined, and you specifically has defined that they've recovered, specifically with fever resolved without taking any medications, and their actual symptoms, the cough, dyspnea, etc., is resolved. Additionally, you're looking for 7 days since the symptoms initially appeared. So this gives some very specific guidelines around patients that can go home, and also for environments where testing is particularly limited. And when I say limited, we're also talking about limitations in terms of timeline in accessing results. For the test-based, which is really, I think, focused on patients that are going to long-term care facilities or skilled nursing facilities, you want to make sure that the patient is fever-free, that, again, their symptoms are resolved. And to the point that's been made for a lot of skilled nursing facilities, there needs to be at least one negative test that's associated. This says that ideally that they're two separated within 24 hours. And I'll get into what a lot of our skilled nursing facilities have communicated as a general policy in terms of addressing this. But again, reiterate, you have to be a clinician, make the decisions, and I think advocating for a symptom-based discontinuation of precautions probably makes a lot of sense given the feedback that we've had from the field with respect to the turnaround timeline for test results. One of the things we wanted to make sure to address, not only for our own SNFist population, but quite honestly for our acute care teams, as we are communicating with our partner SNFs, whether they're high quality networks or not, is do you guys have a particular protocol or approach to looking at accepting these patients? A lot of what we've been hearing has been resistance from skilled nursing facilities in terms of accepting these patients. And obviously our goal is if we can get them home, to get them home with appropriate home health supervision and ideally tele-home health in order to mitigate additional exposure. But in terms of thinking what we want to communicate back to skilled nursing facilities, this list that comes from the American Healthcare Association and the other entity, which is the National Center for Assisted Living, both associated with long-term care patients, are really based on their most recent guidelines. You can see what's listed here. Again, it's if a patient can be accepted, try to get them in a single room, make sure that they've got contact precautions, monitoring for other symptoms, limiting both staff and other residents to whom they would be exposed, and quite honestly, looking for opportunities to cohort patients, even including moving residents from where they've been, so that way it can be isolated in terms of treatment and the number of staff that are exposed to either COVID positive patients or just the staff that can potentially become spreaders within a given facility. The next slide really goes into additional guidance and at least a framework that the AHCA and NCAL have outlined in terms of ways to accept these patients. And I think we won't go through anything that's here because it won't have a significant amount of time to go through this and make sure the questions are answered. But I do want to make sure to highlight that, first off, the numbers that are on here refer to the numbers on the prior slide. And the second is to underscore that there actually is a framework for skilled nursing facilities to accept these patients. We want to make sure that if we have an active post-acute program and an active post-acute presence, we're providing visibility to this. If we don't, and we are obviously partnered either via a high-quality network or just our regular partnerships in a community, we want to make sure that these are in the hands of those folks so that way they have very clear visibility on how to accept these patients and ways that they can be cared for, so that way we're effectively managing the resources in that area. We're effectively managing we're effectively addressing our commitment to the hospitals in terms of managing these patients according to our abilities and knowing that that they have a very clear way to be discharged into these facilities. This will be expanded upon certainly within the hospital medicine webinar that's coming Thursday, but I think we're also making sure that in consideration of discharges, the same thing that Sergio reiterated earlier, which is at the front end in terms of emergency medicine and patients potentially coming into the hospital, that those advanced care planning discussions that we've always advocated for in Sound are considered then, certainly when they're in the hospital. And I think that there's another opportunity for us to do the right thing for our patients by considering it at discharge, to also help guide our skilled nursing facilities as well as the patients in terms of whether or not they want to return to the hospital. So that way there's visibility and patients don't unnecessarily come back to the emergency department or come back to the hospital when they don't want to. I will end there and turn it over to Mark to go over the resource list and questions.
Thank you, Greg, and thank you also to Nate and Sergio. Great presentation. Very, very encouraging that we have so much more information than we did 4 weeks ago. We have time for a couple of questions. We can stay a few minutes late. First question, is coughing an aerosol generating procedure? And if so, shouldn't we have all encounters with persons under investigation or COVID positive patients with N95 masks on?
So I'll take that. And I think that the coughing has not been documented as an aerosol producing procedure in terms of what it really generates is droplets. So that's why somebody who's coughing who has a mask on and you have the mask on and you keep the right distance, it's hard for you to get there. The idea of the aerosol plausibility comes from data that we showed earlier in other webinars where under experimental conditions, they're able to generate droplets that are small enough and that persist in the air, but that is not felt to be the same dynamic as coughing. So coughing clearly produces droplets, and I think that what you need in those situations, if we have N95s, I mean, you should always use them in a COVID positive patient, but I think that the reality is that most places are trying to optimize the use of N95s, so that might not be possible, but you can definitely decrease the droplet exposure by masking the patient and having the appropriate droplet precautions yourself.
Okay, thank you. If patients require a non-rebreather and seem to be tolerating well, is it safe to keep them on a non-rebreather with an O2 sat around 92%, especially knowing that we are out of high flows and BiPAP?
Well, I think that that's a difficult question in terms that it depends on the patients. I suspect that some patients might do fine and others probably gonna need to be intubated. And I think that that's where just, I mean, unfortunately, being a clinician and monitoring these patients frequently is most important, which obviously when you have triple capacity of what you usually see might be difficult. But the best I could say is that you need to assess the patient. If they're stable, if they're doing fine, you can watch them. But if they start having trouble, obviously, and at 92%, they might drop very quickly. They might need to be intubated.
Okay. Next question. Are there guidelines for the timeline for a second COVID test for patients with a first negative test but a high suspicion for disease? Should it be 24 hours between the tests or not?
Well, if you think the patient has the disease and you have a high pretest probability, you may not need to do subsequent tests. You know, I think that if you want to do multiple tests, thinking that, you know, a subsequent test will be positive, you have a couple of options. If you have a patient that's, you know, intubated or in the ICU, the predictive value of tests where materials acquired from the lower respiratory tract, you know, i.e. through suction through an ET tube, is much better than that the tests where the samples obtained through a nasopharyngeal swab. Another option, you know, if the patient's able to go home, would be to just treat them as though they have the disease and assume that the first test was a false negative. If you were going to try and use a strategy that involved a second test, the recommendation is that the test be separated by 24 hours and that the samples be handled independently.
Okay. Next question. We have seen some early success minimizing oxygen escalation, including intubation by gentle diuresis if normotensive and normal renal function. Wondering if you have seen a similar trend.
So that I think is aligned with what we presented and what people are seeing in terms of management of these patients in terms of fluid, except for those who come in early on with a lot of fevers or who are hemodynamically unstable, is to be more conservative and then just try to diurese them as soon as tolerated. And I think that you mentioned the question two important aspects, that the renal function is normal, that the patients are overall seem to be euvolemic or hypervolemic. And I do believe that there is obviously a benefit in keeping these patients dry. You just have to be very careful and not overdoing it when they first come in, I think. But people have reported that as well.
Okay. Should video laryngoscopy be a standard for intubating these patients?
I don't know. I think that that's a great question. I do believe that it's recommended when available. And I think that if you have it, you should use it. And if you don't have it, you probably should try to get it. But I do think that saying a standard, I think, is a high bar with the amount of evidence that we have. The theory behind it applies, like I said, to two issues. One is that in general, the first pass rate will be higher with the video laryngoscopy than direct laryngoscopy. And number two is that in theory, it might decrease the exposure for the operator, but that has not been proven. But I do believe that if you have it, you should be using it.
I think I'd add one comment to that, which would be, I don't think during this is a time to acquire a new skill at the bedside. So, whatever tactic or technique or device that the most experienced operator is familiar with that will lead to the shortest time to an inflated cuff on the ET tube would be recommended. There are many experts that recommend VL, video laryngoscopy, but if that's not readily available and you have an experienced operator with direct laryngoscopy, go ahead and use it.
Yeah, that's a good point, Nate.
Okay, awesome. We're almost at 5 minutes after the hour. I'd like to ask each of you to, just make a closing comment, or perhaps what's the number one thing you want everybody to take away from today's presentation. Nate, do you want to start?
I think that the thing I'd like people to take away with is just the sense of pride and awe that I have, and I know Greg and Sergio share, at the dedication and get things done attitude that we've seen amongst frontline providers. All of the service line CMOs have faced, tremendous challenges at some of our sites over the last week, and we certainly will continue to face challenges as, the disease peaks in many of our communities. And, I guess in terms of something to leave the group with aside from that, I would say that, this content is created, by us with a lot of help for you. So if there's anything you'd like to hear about, if there's some way we can make it better, send us a note. Hopefully we're all easy to find.
Thanks, Nate. Sergio?
I think that what I would say is that everybody is obviously undergoing tremendous challenges with COVID-19. You're going to see a lot of patients in some places. Don't forget that that patient is not a COVID-19 patient. It's somebody's father, somebody's mother, somebody's spouse. And I do believe that it would be great to have the new and latest therapies for these patients, but we don't have that right now. But there are things that we can do. And sometimes, recognizing the human part of this and how it affects everybody is probably more useful, more powerful.
Greg?
I want to reiterate what Nate stated in terms of awe. I think that's the fantastic word to choose about just everyone's response to this pandemic and to treating patients, and really figuring out how best to support the patients and families and our hospital partners in the communities. We really do want to make sure that this is useful time. We appreciate your taking the time to join us. Want to make sure that, again, the information remains useful to you, and we'll continue to answer questions. But I want to reiterate my personal gratitude and just pride in being a part of the Sound team and family as we are managing through this pandemic.
Thank you very much, Greg. Thank you, Nate and Sergio. Thanks, Rob, and also Dr. John Berkmeyer for all the work that he is doing. And I'll just reiterate my thanks, and I'm also awed by everything going on the front lines. We will get the recording of this webinar out to everybody later today, as well as links to some of the really useful resources that were pointed out. And we thanks for your time and your ongoing efforts. Talk to you soon.